Hello, everyone, and welcome to today's webinar, Impacting Patient Outcomes with Rapid Positive Blood Culture ID Utilizing MALDI Mass Spectrometry. I am Tracy S. Martin of Labroots, and I'll be your moderator for today's event. Today's educational web seminar is presented by Labroots and brought to you by Bruker Daltonics. To learn more, visit bruker.com. I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. Also, please notice you can share this webinar on your personal social media. Just click on the Social Sharing tab to let your friends and colleagues know about today's live event. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, Mr. Ike Northern. Ike is the Director of Infectious Disease Testing and Immunology at Compunet Clinical Lab in Dayton, Ohio. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Ike, you may now begin your presentation.
I would like to thank you for joining today to discuss the use of the Bruker Multitof Sepsityper. The learning objectives for today's talk include an explanation of the clinical presentation of sepsis and the importance of laboratory testing. We will also describe the advantages of using rapid diagnostic tests on positive blood cultures and discuss current technologies used for rapid identification. Then I will outline the experience with Bruker Sepsityper that we have had. Lastly, we will review a couple of patient cases where Sepsityper was used to identify the isolate in a blood culture and the impact it had on patient care. Compunet is a regional laboratory that services 5 hospitals, 2 standalone emergency rooms, and hundreds of doctors' offices. Microbiology testing for hospitals is consolidated into one location. Our laboratory has a full-service microbiology lab that includes all of the major subspecialty areas, such as bacteriology, parasitology, mycology, AFB testing, serology, and molecular testing. We have 46 employees in our microbiology department that work on all 3 shifts, in addition to 11 employees that work in serology and the molecular area. Blood cultures are drawn at each hospital site and are sent to the microbiology lab for incubation and testing. We do about 5,000 blood cultures per month. Before talking about testing, let's do a review of what sepsis is and its implication for the patient. Sepsis is the body's immune response to an infection. This is caused by a dysregulated immune response that can be extreme and affect multiple systems in the body. In many cases, this is a life-threatening illness. According to the CDC, about 1.7 million Americans develop sepsis each year, and about 270,000 of them die. About 1 out of every 3 patients in the hospital have sepsis, and it is the 10th most common cause of death in the U.S. Sepsis can be divided into 3 categories depending on the severity. In sepsis, the patient will have fever, increased heart rate, rapid breathing, and other signs of infection. These patients have an 18% mortality rate. In severe sepsis, all of the symptoms of sepsis may be present, but the patient will also have organ dysfunction, and the mortality rate increases to 40%. The most severe form of sepsis is septic shock. These patients have the symptoms that have already been mentioned, in addition to a drop in their blood pressure. 60% of the patients that develop septic shock will die. So what is the laboratory's role in diagnosing and treating sepsis? Along with the clinical symptoms, there are a number of lab tests that can be used to help diagnose sepsis. An increased white blood cell count is an indicator of infection, and as is an increased monocyte distribution width. An increase in the lactic acid level is indicative of organ dysfunction found in severe sepsis and septic shock. A blood gas can be used to evaluate the acid-base changes found in sepsis, while procalcitonin helps differentiate bacterial from viral infections, and it is increased during sepsis. Blood cultures permit the growth of the causative agent of sepsis, allowing identification of the organism and susceptibility testing. Lastly, a urine culture can help determine if the sepsis symptoms are caused by seeding of the bloodstream with an organism causing a urinary tract infection. Let's talk about blood cultures in more detail. Normally, 2 to 3 sets of blood cultures are drawn when sepsis is suspected, and usually includes both an aerobic and an anaerobic bottle. Within 24 hours, about 3/4 of positive blood cultures will become positive. Another 15 to 20% will become positive within 24 to 48 hours. The positive bottle is subcultured, and the organism typically grows after overnight incubation. Using traditional microbiology techniques, the identification of the organism is completed in 18 to 40 hours. The susceptibility testing is completed in 36 to 48 hours after the culture bottle flags as positive. You can see the list of the most common organisms that we see in our laboratory. These 10 organisms account for 75% of the positive blood cultures. Over the past 5 to 10 years, there have been a number of new diagnostics tests that allow for the rapid identification of blood culture isolates. So why is this important? When a patient has sepsis, studies have shown that the sooner they are placed on the appropriate antibiotic, the better their outcome will be. For this reason, patients that are suspected of having sepsis are placed on broad-spectrum antibiotics to treat the causative organism prior to the blood culture becoming positive. The ability to use rapid identification methods to get the patient on the best antibiotic has a number of advantages. There's less exposure to unneeded antibiotics, which in turn reduces the risk of resistance development and other side effects. The patients also have better outcomes with reduced healthcare costs. Since the broad-spectrum antibiotics are used empirically, some patients are placed on antibiotics that are not effective against the causative agent. Mortality increases each hour the patient stays on the wrong antibiotic. Rapid diagnostic tests help shorten the time required to get them on the correct antibiotic. There are a number of tests on the market for rapid identification of blood culture isolates. Let's discuss each of these. The first test is the DNA FISH test by Opgen Advantix. This assay utilizes DNA probes that are tagged with fluorescent chromophores. A gram stain is performed to determine which reagent kit to use, and blood from the positive bottle is placed on the slide. The reagent is then added to the slide, and the DNA probe is allowed to bind with the nucleic acid of the organism in the sample. The reaction takes 20 minutes, and the slide is read by using a fluorescent microscope. The color of the organism on the slide is based upon the DNA probe which attached to the organism and determines the identification. For example, in the gram-negative bacilli kit, there are 3 DNA probes. If E. coli is present, the organism will stain green. Klebsiella pneumoniae will stain yellow, while Pseudomonas aeruginosa stains red. There are kits for 4 separate organism groups, including Staphylococci, gram-negative bacilli, Enterococcus, and Candida. BioFire manufactures the film-array blood culture identification kit. This is a multiplex PCR test that allows identification of 26 bacterial targets and 7 yeast targets. In addition, 10 resistance genes are detected along with the organism identification. All organisms and resistance genes are detected using a single cartridge. In this assay, an aliquot of the blood is injected into the cartridge that is shown in the lower left corner of this slide. This cartridge contains all the necessary reagents to perform the multiplex PCR. The cartridge is placed in the instrument, and results are available in about an hour. Luminex Varigene also produces a multiplex PCR test. They differ from the BioFire in that there is a separate panel for gram-positive and gram-negative organisms. The gram-positive panel detects 13 bacterial targets as well as 3 resistance genes. The gram-negative panel detects 9 bacterial targets with 6 resistance genes. Like the BioFire assay, the blood is injected into the cartridge and placed into the instruments. Results are available in about 2 hours. Genmark is another company that makes multiplex PCR assays for blood culture identification. They have 3 separate cartridges. The gram-positive panel detects 20 bacterial targets and 2 resistance genes. In addition, the cartridge contains probes for pan-gram-negative and pan-Candida targets, allowing you to detect mixed infections, or it directs you to the use of another panel when the gram stain is questionable. The gram-negative panel detects 21 targets with 6 resistance genes. It also contains probes for pan-gram-positive and pan-Candida targets. The third panel is a yeast panel that contains 15 targets. Just like the other multiplex assays, an aliquot blood is taken from the bottle and injected into the cartridge. Once placed in the E-Plex instrument, the test takes about an hour and a half. The last rapid identification method we will discuss, and the main focus of my talk today, is the Bruker MBT Sepsityper. This method utilizes the Multitof technology and has the potential to identify any organism that is contained in the Bruker Multitof database. Identifications may be batched or performed individually. When performing a cost analysis of different rapid identification methods, the Sepsityper was least expensive for us. Before we talk more about the Sepsityper, let's review the theory behind the Multitof method. Multitof is an acronym for Matrix-Assisted Laser Desorption Ionization Time of Flight. It uses mass spectrometry that was initially used in microbiology to identify organisms growing on a culture plate. To perform the identification from a culture plate, the organism is inoculated to the target plate, as shown here. In the direct method, the organism is placed directly onto the plate. Depending on the organism, it may be necessary to use the extended direct method, which uses formic acid to break down the cell wall prior to inoculating the target. Organisms with a thick cell wall may require an extraction prior to inoculating the plate. Once the organism dries on the target plate, a matrix is added, which absorbs the irradiation of the laser and helps the ionization of the particles. The target plate is then placed into the instrument. Once the target plate is in the instrument, a laser is emitted that will strike the organism well on the plate. This causes 2 things to occur. The organism is vaporized, and the particles that are created are ionized, giving them a positive charge. These charged particles are then accelerated toward a detector plate by the potential difference between the target and the electrodes. The mass and charge of the particles determine how long it takes for them to hit the detector plate. As a result, small particles with a small mass hit the detector plate first, and larger particles follow behind. This is known as the time of flight, or TOF. As the particles hit the detector plate, the time of flight and the intensity are measured for each particle size, and the data is plotted on a chart. The x-axis is the mass charge, and it is plotted from the smallest to the largest. The y-axis is the intensity and is determined by the number of particles of a particular size. The greater the number of particles, the higher the peak. In the Multitop software, there is a spectral data for hundreds of different organisms. For each species, there are multiple spectra. This allows various strains of the same species to be identified. You can see from the spectral data shown here that each species has its own unique pattern based upon the particle size and intensity. The Multitop software uses an algorithm to calculate a Multitop biotyper score. This score is determined by comparing the number of peaks of the unknown sample with the number of peaks of organisms in the spectral library. In addition, the intensity of the peaks are factored into this calculation. Once a score is obtained, it can be used to determine the probability of a correct identification. A score of 2.0 to 3.0 is a high confidence identification and may be reported with the genus and species. 1.7 to 1.999 is a low confidence score. The genus in this score range is usually accurate, but the species is questionable. Scores below 1.7 is a low score and does not provide an adequate identification. Bruker has developed a blood culture rapid identification kit based upon the Multitop technology, known as the MBT Sepsityper. This kit allows for identification of blood culture isolates directly from a positive blood culture. 50 identifications can be performed from one kit, and the shelf life is up to 24 months and may be stored at room temperature. There's a dedicated software module that is loaded onto the Multitof instrument that is used specifically for the Sepsityper kit testing. This is a dedicated software, and in this software, the mass range that is used for the identification is slightly more narrow when compared to the regular Multitop software. The reason for this slight restriction is that there are multiple peaks that are found in the lower mass range that are due to blood cells in the sample. You will also notice from the chart that the MBT scores for acceptable identification are lower. The reason for the lower score thresholds are due to unwanted peaks that are found throughout the mass range when using the Sepsityper. As a result, there is a bit more variation between the library spectra and the Sepsityper spectra, producing a lower score. To perform an identification using the Sepsityper, there is some sample preparation that must occur. First, 1 ml of the blood is removed from the positive bottle and placed in a conical tube. Lysis buffer is added and mixed for 10 seconds. The sample is then centrifuged for 2 minutes, and the supernatant is discarded. After adding a wash buffer, the sample is mixed again and centrifuged for 1 minute. The supernatant is discarded, and some of the pellet is transferred to 2 spots on the target plate. Formic acid is added to one of the spots, and then both spots are allowed to dry. A matrix is placed on each of the spots and allowed to dry. The sample is now ready to be placed into the instrument and to be tested. If no identification is obtained, an extraction may be required in order to get an identification. The extraction causes disruption of the cell wall of the organism prior to putting it on the target plate. When we made our decision to try Sepsityper, a validation was completed prior to implementation. We tested 106 positive blood cultures using both the Sepsityper and traditional identification methods, such as a microscan and staph latex. We compared the identification obtained from the Sepsityper to the identification from the traditional methods. An acceptable identification was obtained on 82% of the isolates. No identification was obtained on 18% of the isolates. 3 of these organisms had no peaks, which indicates that there was no particles hitting the target plate, and 16 had low scores. The lack of identification may have been due to technologist technique or to low-level bacteremia. During our testing, we noticed that E. coli were identified as E. coli/Shigella. The protein structure of these 2 organisms are so similar that it's not possible to separate them using the Multitof. We also had one culture that contained 2 organisms, Escherichia coli and Pseudomonas aeruginosa. In this case, the most predominant organism, E. coli, was identified. Here's the list of the organisms that we tested, along with a number of isolates of each. The left side shows the organisms that were identified to the species level, while the right side shows the organisms that were identified to the genus level. This chart lists the organisms that did not produce an identification. And you can notice that some of these organisms are slow growers or anaerobes, or that sometimes will produce a not much growth in a blood culture bottle. During our validation study, one thing became very obvious. Technologist technique matters. When initially starting our validation, we tested 29 samples. During this pre-validation phase, 55% of the organisms did not achieve an identification. We did not feel that we could proceed with this level of performance. However, during this time, one of our technologists who had a molecular background was being trained to notice that the technique being used to remove the supernatant was not protecting the organism pellet. She suggested a minor modification in technique based upon her molecular experience that resulted in a significant improvement in the number of identifications. Since our validation, we have also noticed that technologist variation still occurs. If you intend to use a Sepsityper, you should plan to monitor success rates of each employee and retrain when you note an employee is not achieving a standard identification rate. Once we saw that the Sepsityper worked well in our laboratory, we implemented the test using this algorithm. We first perform a gram stain, subculture the bottle to solid medium, and call the critical value. If multiple blood cultures are positive, we perform the Sepsityper on the first positive set only. After discussing this new technology with our infectious disease physicians and explaining the process of testing, we decided to run the Sepsityper twice per shift and also to add comments, which we'll discuss in a minute when appropriate. When the Sepsityper is done, we notify the pharmacy for the appropriate hospital, and then they will review the patient's chart, and if it looks like an antibiotic may need to be changed based upon this identification, the pharmacy contacts the physician. The traditional susceptibility is then performed. One of the key pieces to our algorithm is a notification of the pharmacy so that immediate action can be taken. Studies have shown that if rapid identification methods are utilized without a process to take immediate action, the value of the rapid testing is diminished. The comments that we attach to the Sepsityper report are listed here. Since we started the Sepsityper with the investigational use kit, we added a comment indicating such. When an identification of E. coli is obtained, we report the second comment. Since E. coli is a common organism found in the bloodstream and Shigella is rarely isolated, it seemed reasonable to let the physicians know that it is likely an E. coli. During the validation, one beta strip did not match the Lancefield group of the traditional method. So when we get a beta strip identification, we wait for the traditional identification to report the Lancefield group and report the third comment. MALDI also cannot distinguish between strep pneumoniae and strep mitis. When we get one of these identifications, we report the last comment. We compared the time frame for obtaining the identification and susceptibility of a blood culture isolate when using the Sepsityper compared to the traditional methods. There's a significant difference in the identification portion, but no significant difference for the susceptibility. Once the identification is complete, the institutional biogram can be used to adjust the therapy when necessary. When using Sepsityper, this can occur 1 to 2 days earlier than when using traditional methods. Now I'd like to discuss a couple of case studies to show how Sepsityper has improved patient care. Our first study is a 77-year-old female who was admitted to the hospital for weakness and failure to thrive. Blood cultures were collected in the emergency room, and vancomycin and pip-tazobactam were started empirically. On the first day of hospitalization, the blood cultures were positive for gram-positive cocci that are seen here in this gram stain. The Sepsityper kit results identified the organism as an Enterococcus faecalis, which was reported to the pharmacist who is part of the antimicrobial stewardship team. And an infectious disease physician was consulted, which immediately stopped the vancomycin and pip-tazo after 24 hours. Based on the local antibiogram, ampicillin and gentamicin were initiated, and an order for a transesophageal echocardiography was ordered, or a TEE. On the second day of hospitalization, the TEE was performed, which revealed a large vegetation on the mitral valve. The patient was evaluated by the cardiac surgeon on the day of the TEE, which recommended medical management only. The patient was given 6 weeks of ampicillin and gentamicin without issue. The second case is a 41-year-old male with a complicated and prolonged hospitalization that followed an abdominal surgery. He had developed fever and an elevated white blood cell count on hospital day 21. His PICC line had been present since admission. Blood cultures were collected, and vancomycin, ceftriaxone, and fluconazole were started empirically. On hospital day 22, blood cultures were positive for gram-negative rods, and the Sepsityper demonstrated Enterobacter cloacae. The antimicrobial stewardship team was notified, and the fluconazole and vancomycin were discontinued based upon the gram stain and the Sepsityper results. The antimicrobial stewardship team noticed that 3 months prior, Enterobacter cloacae was found in the urine culture of the patient, and so they recommended changing the ceftriaxone to meropenem while sensitivity results were pending. Microscan results available on the hospital day 24 confirmed that the Enterobacter was a ceftriaxone-resistant strain, and therapy with meropenem was continued for 10 days. His PICC line was exchanged, and the patient responded well to therapy. Reimbursement for Sepsityper testing is dependent upon the structure of your laboratory. Payment for testing on many hospitalized patients is included as part of the DRG reimbursement that hospitals receive for patient care. For commercial labs, there are several codes that may be used to receive payment. Since I'm not a billing expert, I can't recommend codes for your lab, but I can tell you what we do. We use the codes listed here to bill for organism identification, and since there's a concentration procedure that is being used to prepare your sample for testing, we bill and receive payment for that concentration step. Before implementing the use of the Sepsityper, we performed a cost analysis to see how it would compare to other methods. We perform about 60,000 blood cultures each year with an 11% positivity rate. That means we have about 6,600 positive blood cultures per year. Since most patients have multiple blood cultures drawn and often both are positive, we perform Sepsitypers on about half, or 3,300 blood cultures each year. We estimated that the multiplex PCR panel costs about $105, and the cost of the multiplex testing would be almost $350,000 per year. The cost of the Sepsityper is about $9.50 each. Each year, the Sepsityper cost would be almost $63,000. In addition, it's more time-consuming to perform the Sepsityper when compared to a multiplex PCR assay. I estimated that I needed to add an additional 0.6 FTE in order to perform this testing. The difference in the tech time expenses between performing the multiplex PCR and performing the Sepsityper was about $38,000 per year. When you subtract the cost of the Sepsityper kits and the tech time from the cost of the multiplex PCR panels, the Sepsityper was about $250,000 less expensive than the multiplex PCR assays. We found the Sepsityper provides rapid results that allow the physician to adjust therapy up to 48 hours earlier than traditional methods. Earlier de-escalation or administration of targeted antibiotics can be accomplished when the identification is reported earlier and can also result in a change from IV antibiotics to oral drugs. These factors result in improved patient care, reduced length of stay in the hospital, and the associated costs with that. Physicians have been very satisfied with the ability to obtain rapid blood culture identifications. The chairman of the Antimicrobial Stewardship Program, Dr. Steve Burdett, indicated that the use of the Sepsityper has allowed him to adjust therapy quicker. At times, this has resulted in narrowing the therapy, and at other times, it has allowed him to escalate to more appropriate antibiotics. The physicians have become so accustomed to getting these rapid results that we had to inform them each time we have Multitof maintenance so they understand why they're not getting their rapid results as usual. In closing, Compunet is currently using a research use only Sepsityper product, but we plan to move to the FDA approved version as soon as possible. Since it is an RUO assay, we developed and validated our own protocols for in-house testing. I'd like to thank you for your attention and would be happy to entertain questions at this time.
Thank you, Ike, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have any questions you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. Okay, so let's get started. Let's try again. Our first question, Ike, is could you quickly please review the no ID results on slide 27? What exactly is included in this category?
So the organisms that we did not get an identification on are listed on this slide, and you will notice that these organisms are, some of them are anaerobes, and lactobacillus is an organism that tends to grow slowly in the blood culture bottles. Strep pneumo is also an organism that we know that doesn't always grow very well in a blood culture bottle. And so these were not really surprising to me. Some of the ones that I was a little surprised about was the coagulation negative staph. However, if you have a low level bacteremia, you may not get an identification on these. And the reason for that is when you are processing your samples, you're trying to create a pellet of the organism. And so if you have just a very small amount of the organism present, you may not be able to get a good graph to be able to compare it to the library. And so what we did find, though, is that when we got an identification, it was an accurate identification. We did not have problems with getting a wrong identification. So and this is true when we're doing Sepsityper or just identifications from a agar plate. We either get a good identification or we just don't get an identification at all. And so in my opinion, that's what I prefer, is to not get an identification than to get a wrong identification.
Is this currently FDA cleared on the Bruker MALDI?
It is not an FDA cleared process or kit. It's a research use only kit, and we have validated it in our laboratory for this testing. And so when we did our validation study, we looked at the organisms that are the most common things that we see in our blood cultures, and we did a validation to be able to allow us to be able to identify them based upon our information here. And so my understanding is there is an FDA approved kit that's in the works, but it's not available yet.
Thank you. Our next question is, did you put microbes in the Multitof with buffer or with media?
Well, you actually take media from the bottle, from your positive blood culture bottle, and put it into your, do the sample processing step in order to get your pellet of organism.
For validation, can you use blood culture aliquot at -80 degrees within 8 hours of being unloaded from blood culture instruments?
Well, we did not try that, so I'm not sure what effect that would have on these organisms. Of course, when you freeze organisms, that can kind of damage them a little bit, and so it may be possible. We just didn't try that when we did our validation study.
Okay, the next question is, exactly what technique was changed when removing the supernatant to protect the pellet?
So one of the things we found that when we did our initial training of our technologists is that they were going in with a pipette tip and trying to suck out the supernatant. And we found that some of the technologists were actually sucking the pellet of the organism out of the bottom of the tube. And so when we had our technologists that had the molecular diagnostics experience being trained, she noticed that was a real potential, and she suggested that we would, when we put our tubes into our microcentrifuge tube, that we make sure that we place them in a certain way, and that when we and of course when you spin them down these microcentrifuge tubes, they're at an angle, and so your pellet kind of goes up on the side of the tube. Well, she suggested that whenever you take off your supernatant, that you go in there with your pipette on the other side of the tube so that you're not disturbing that pellet that's present there. And so we made that minor change, and it had significant impact and improvement in our results.
Very powerful presentation. How well did your staff seem to adapt to the change in workflow?
Well, it took us a little while to get people used to this, but they found fairly quickly that they could get these results out to the physicians quickly, and they were happy about that. Now, it does take a little bit of time. We do 6 batches a day. We do 2 batches of testing on each shift, including third shift, and it takes about 20 minutes to do that, the process of processing samples. Now, keep in mind, we do about 5,000 blood cultures a month, and so a lot of times we're processing 10 to 12, 15 samples at a time. And so it takes about 20 minutes to do that, the processing step, and then then we put it on the Multitof. And so we actually made some adjustments in our workflow in order to have a person that was designated just to do Multitof. And that actually was something that we did when we first got our Multitof instrument. We noticed that in order to really use this effectively, we really needed to change our workflow from the normal processes that we have been using. So we adjusted things to allow this one technologist to be able to just focus on this. And so when we did that, it created less stress for the employees, and they seem to respond very well to it. And it's also made it easier sometimes if you have multiple people that you're trying to train at one point. You know, if you get a new technologist, it takes a little while to train them to do plate reading. And so if you have someone that's training on plate reading and you want to train someone on something different, this is a good bench, and it's fairly easy for a new technologist to come in and learn. And so they've actually responded very well to this and have done very well with being able to get these results out in a timely manner.
Did you face any resistance among the physicians regarding providing an ID without the susceptibility results?
Well, we are providing a susceptibility result, but it's in the normal time frame that they get the results. Actually, our physicians were the ones who drove a lot of the interest in this. The Antibiotic Stewardship Committee was looking at ways to decrease or to change the antibiotics to make sure the patient gets on the appropriate antibiotics more quickly. And so they were all for this. I mean, they were really interested in us coming up with some method to get a rapid identification. And in fact, we actually looked at several different methods, and we were getting ready to go with another method instead of this. But then when we realized that our Multitof had been approved in the budget and that we were going to have this, we decided that we're just going to wait and not go with this other method. Because it had a limited number of organisms that we could identify. And with the Multitof, like I mentioned, you would be able to identify essentially any organism that's in the Multitof's database.
There are no resistant gene markers that can be detected by this method. What does your antimicrobial stewardship committee's thoughts about that?
Well, we talked about that particular issue, and we've tried to decide what would be the best option for us. And so the organism that they seem to be most concerned about is MRSA, and being able to detect that MRSA on these positive blood cultures. And of course, MRSA is or Staph aureus is one of the very common organisms that we see in blood cultures. And so we did some other methods that we did in addition to the Multitof to help us get that MRSA result. And so what we do is we take an aliquot from our sample, our blood culture sample, and there's a couple different methods that are out there that they're rapid identification methods that will identify the organism plus give you the resistance genes. We were using one method to do this, one manufacturer, and that manufacturer went out of business. But so we stopped doing it for a while, and we're ready to start that back up again. But by taking the blood culture from these bottles, we can do this rapid identification test that will give us like that identification and the resistance mechanism in addition to that. And so we decided that would be the best way to go for the Staph aureus because it allows us to do that additional testing just for the blood cultures have Staph aureus. Now, for the gram-negatives, that's a little bit of more of an issue, and we are looking at some other alternatives for that that will, I think, down the road that will help us with that to be able to give a more rapid or susceptibility or the resistance markers for those.
We have a lot of questions coming in. Our next question is there a difference in performance with different blood culture media?
Well, since we only use one media, that's actually not true. When we started doing this, we acquired some other hospitals, and they were using a different blood culture media, a different blood culture system. And so when we did our validation studies,
when we got these new instruments, we had to do another validation study for the other type of media, and we really didn't see any difference between the different medias. What we did see is the difference, though, in the performance from one technologist to the other. And so it is important, like I mentioned in the presentation, that if you are going to use this, the Sepsityper, that you do probably want to monitor your performance of your technologists. We have some technologists that have very few no IDs or no peaks, but then we have other technologists that they're much higher. And so when we see that kind of thing, we want to make sure that we do proper training, and to make sure that the technologists are following our protocols, and also learn the techniques of not sucking that pellet out of there in order to get a good identification.
Thank you, Ike. Our next question, let's see, we have so many. What about the sensitivity or specificity? Did you validate against traditional culture? Are you still doing cultures as a backup?
Well, this identification method is from a culture, so you're not replacing the culture. You're just doing a rapid identification from that culture, and so you still have your blood culture bottle. You still do your gram stain. You subculture your bottles and those types of things. For us, we do the gram stain. We get that results to the physicians immediately as a critical value, and then we do the Sepsityper. Since we're only doing that a couple of times a shift, we need to make sure that they're getting that identification. So and then we have to have an organism on a plate in order to do the susceptibility testing. So we are continuing to do a routine blood culture. We're just adding this additional piece in there to help us get a quicker identification. And then the physicians can use that information to adjust their therapy when it's appropriate.
Thank you, Ike. Our next question, is that 20-minute processing step per sample or per batch?
That's a per batch. And one other thing, too, with our method that we're currently using, this was the initial protocol that we developed. But now there's a more rapid, streamlined protocol that we've actually validated, but we just haven't put into place yet. And it will actually streamline it just a little bit and probably reduce that processing time by about 5 minutes or so.
Our next question. How often did you need to perform the extraction method?
Actually, we don't usually perform the extraction method. Since we have a culture that we're working with, we can get an identification usually the next day if we need to do that. The main goal here is to get a rapid identification. If you have to go through that extraction process, it takes a little bit longer. And our physicians didn't feel like that was necessary. And that's what it says in the procedure or the package insert from the kit, but we don't typically use that. And so, if you look at the organisms that we isolated, we would not normally need to do that extraction method based upon the organisms that we're isolating from our blood cultures.
Ike, have you seen any false positive results?
I'm not sure what they mean by false positive results, but we haven't found that it's given us organisms that were giving us wrong information, if that's what the question was. We know that we're not going to pick up everything because of sometimes the technique of the technologists or these low bacteremias, but we haven't really found anything where I consider a false positive result.
Okay. I apologize if I mispronounced this word. The next question is, how do the rates of identification using the Sepsityper compare to those when using the multiplex PCR?
I'm sorry, did it say the rates of the identification?
Yes, the rates of the identification.
Okay, so it's actually fairly similar. When you look at the list of organisms that I showed on my PowerPoint, those 10 or so organisms account for about 75% of our organisms that we see. And so each of the multiplex PCR assays have a list of organisms that they can identify. And so as long as you're, you have a little bit more sensitivity with the PCR test because you're doing PCR. And but if your organism doesn't fall into that database, then you're not able to identify it. With the Sepsityper, you have the possibility of identifying pretty much anything that's in their database. And so the rates are fairly similar with your detection of or getting an identification.
What is the lowest acceptable score you use as an acceptable ID?
Well, we have a, if you look at the slide that, let me see if I can find that slide here, the slide that gives you the scores. So that score, let's see, it's a 1.79 is what we've considered a low positive result. And when we get anything below a 1.8, I'm sorry, 1.6 is the lowest positive score that we would use for an identification. So 1.6 to 1.79, we could identify those organisms to genus level and report the genus. In order to be able to give an identification, we would need to have a 1.8 or higher.
Thank you, Ike. Do you have any data from pharmacies, such as savings in antibiotic days, antibiotic cost, or length of stay?
That data is extremely difficult to come by. You have to do fairly extensive studies, and we haven't actually collected that data, but we have had a number of anecdotal type of scenarios where we've been able to show that this really did improve the patient care. They were able to change their antibiotics appropriately, and really when you can look at the cost of this compared to one of the things that you're concerned about is a return on investment basically. And if you look at the cost of doing a Multitof Sepsityper, it's really not very expensive. And so if you could do a test that costs less than $10 and can even affect a few patients, that's probably going to have a fairly big impact on the cost, or at least make it equal. Now, if you're looking at your multiplex PCRs, those are fairly expensive tests. And so you would probably need to have a little bit more data, I guess, to back you up. When we started doing this, we already had the Multitof available in our laboratory. We didn't buy the Multitof to do this, but we already had it here. And so we felt like that we could do a fairly inexpensive test that would give us some rapid identifications. And so we didn't really feel like that it was really necessary to do a full study to get that information. That would be great to be able to have that information, but we just don't have that at this point.
We have so many questions coming in, and we have time for just a few more. I want to remind our audience that the questions we were unable to answer today and those that come in during the on-demand period will be answered by Ike using the email address that you provided at the time of registration. So let's squeeze in a few more questions. Our next question is, what was the adjustment that your molecular specialist recommended that resulted in more successful testing?
I think I already answered that question, but it's just the method that we used to pull the supernatant off, making sure we weren't disturbing the pellet.
Did you look at the microbacterial or SSBA organisms?
I'm not sure what that question means. If it's microbacterial questions. Okay. For our blood cultures, we did not. We have validated the microbacterial organisms when we're doing routine cultures, and we are using that to do microbacterial identifications. We haven't really used it for our blood cultures, and of course, you don't get very many positive microbacterium on your blood cultures. But when we've used it for our routine cultures, we do see that it works, and we get correct identifications from it.
Was a verification required for each of your blood culture bottle types or in multiple facilities?
Yeah, so all of our blood cultures are sent to one location. The bottles are sent here. We felt like that, and that was a big discussion about whether we should keep them at the sites or to have them all sent to one place. And we felt like that we may delay them getting in the incubator, but on the backside we had more opportunities in a core laboratory setting to be able to bring them all here and have more things that we could do in the core lab. So, but since we did have two different blood culture systems that we were using at the time, we did have to validate each blood culture system to make sure that they worked with this. And since they were all being done here in one laboratory, we didn't have to, of course, validate for each of the individual hospitals.
Thank you, Ike. Do hospitals use the technology as often as clinical diagnostic?
Well, I'm not sure exactly what that question means, but I can tell you that we do use this on all of our blood cultures from all of the hospitals. And so when a blood culture comes in, we will, and that's positive, we're going to run it regardless of which hospital it's from. And we run it on all of our positive patients. We don't run it on every single sample. So if we have two sets of blood cultures that have gram-negative bacilli, we're going to only run it on one of those. And we also, if we have a blood culture that has two organisms on the gram stain, we do not use the Multitof for that typically.
Thank you, Ike. What percentage of your positive blood culture showed the organisms had a restraint marker present?
Well, since we're not using we're not using an assay that uses a detects for resistance markers. We don't have that now. Like I said, we have tested our Staph aureus, but we're using a different test to do that.
Okay. Can you please explain again the difference between the standard and MBT Sepsityper software?
So there's a specific software that you can use for the Sepsityper. You have your standard software that you use for your bacterial cultures, but when you do the Sepsityper, you are processing a blood sample. And so in addition to having your organism present there, you've got particles of lysed blood cells that are present in your sample. And when you have that, you're gonna those lysed red blood cells produce small particles that are going to be go through your up to your detector plate and be detected there, and you'll see little peaks from those particles. And so the Sepsityper software, the MBT Sepsityper software, actually kind of gets rid of those the lower level of the spectra, and then you will see some additional particles that are from your blood. In the higher spectras of your graph, but the Sepsityper software kind of helps to weed out some of those, and it actually lowers the score that you need to get a good identification because of those lysed red blood cell particles and things that you see from your blood culture bottle.
Thank you. We have time today for one more question. And our final question is this something that you would recommend for a lab that gets few positive culture bottles a day?
Well, if you have a Multitof, a Multitof is a very expensive instrument. And if you have a Multitof for identifying your blood cultures or your routine cultures, organisms from there, it's really a simple process to do this. And so it may be cost prohibitive if you have just very few cultures to purchase a Multitof and to do this. But like I said, if you already have a Multitof in place, it's really not a real expensive test, and it's an easy process. And I think that you will see some impact from the patient care perspective by using this type of technology.
Thank you so much. Ike, do you have any final comments for our audience today?
Well, I would like to thank everyone for listening, for all the questions. There's lots of them here still that didn't get answered. I'd like to thank you for your attention. And we've used the Multitof and the Sepsityper for several years. We've been extremely happy with it, and feel like that it's been a good move in our laboratory to help improve patient care.
Thank you again, Ike, for your time today and your important research. We would also like to thank Labroots and our sponsor, Bruker Daltonics, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Again, questions that we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. We would once again like to thank Mr. Ike Northern for his time today and his important research. We would like to thank Labroots and again our sponsor, Bruker Daltonics, for underwriting today's educational webcast. This webcast can be viewed on demand. Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye everyone.